You're good.
Hi, my name is Ensign Caitlin Cooley, a second-year medical student at Burrell College of Osteopathic Medicine, and I'm here to present a case on ulcerative colitis and hypercoagulability. Ulcerative colitis is a form of irritable bowel disease with an incidence rate of 10 to 20 cases per 100,000 persons per year. It commonly presents with a range of intestinal and extraintestinal complications, including toxic megacolon, colon cancer, arthritis, and venous and arterial thromboembolism. Patients with IBD have a 3 times higher risk of developing a deep vein thrombosis or pulmonary embolism than the general population, and an 8 times higher risk during active flares. Therefore, early detection and prophylactic treatment with anticoagulation is essential in preventing the development of thromboembolisms. For this case, this is a 30-year-old white male with ulcerative colitis who presented to the hospital from a GI clinic for symptoms of tachycardia, palpitations, and presyncope. Symptoms were found to be worsened with bowel movements. Prior to presentation, the patient had bright red blood per rectum for several weeks. Upon examination, he was found to have an enlarged left lower extremity with associated cramping pain, which was worsened with ambulation. His D-dimer was found to be greater than 1050. Initial CTA chest with IV contrast was unremarkable, and left lower extremity Doppler ultrasound showed an occlusive DVT. At this time, the patient was admitted, and cardiology and GI were called. They agreed to start a heparin infusion despite rectal bleeding in order to perform a thrombectomy in the morning. At this point, Ensign Annika Stanley will be telling you more about the patient's hospital course. Thank you.
Hi, my name's Ensign Annika Stanley, and I'm a first year at Burrell College of Osteopathic Medicine, and I'll be taking you through the hospital course. As Ensign Cooley said, on the first day he presented with a left lower extremity DVT, which was occlusive, and on the second day we started on a heparin infusion and proceeded with a thrombectomy with multiple passes and in place a balloon venoplasty so we could put in an inferior vena cava filter placement. The filter is placed below the renal veins but proximal to the bifurcation, and then proceeded with heparin post-procedure and plan to switch to Xarelto 15 milligrams by mouth twice a day. On day 3, he had a code blue where he was having a bowel movement and presented with syncope. After that, he was pale and tachycardic with a heart rate of 160, but his head CT showed no acute intracranial abnormalities. On day 4, there was an extensive pulmonary embolism present within the pulmonary artery, subserving the left lower lobe, but there was no evidence for right heart strain, and we continued with treatment on the anticoagulation drugs of Xarelto, but no thrombolytics. On day 7, he presented with his second lower left extremity DVT, which was again occlusive, similar to the first one. And on day 9, we performed a secondary thrombectomy with thrombolysis and iliac stent placement. And then on day 10, we did another thrombolectomy with left iliac stent placement. He was good up until day 17, where he presented with his third lower left extremity DVT. But none on the right. And on day 20, we did his third thrombectomy with another balloon venoplasty, and there were no complications further from this. And now Ensign Ariana Hudson is going to take over for our conclusion.
Hi, this is Ariana Hudson. I'm a second year at Burrell College of Osteopathic Medicine, and I'm going to first address the figures that we have in our poster. In figure 1, this was what was removed from the thrombectomy on day 2 of the hospitalization. As you can see, it is quite vast for the removal. And then figure 2 is the placement of the IVC filter. It was placed below the renal veins but above the common iliac bifurcation. And then the third figure is an algorithm that you can use in the hospital setting in order to be able to assess and properly manage patients. So some of the questions that we ask is, has the patient already been on an anticoagulant? Do they have a history of VTE? And then, or a family history. If you assess this and you put them at the high risk or medium risk, you would want to admit them and have them stay for 72 hours in order to make sure that you manage their flare-up and their symptoms properly. And some ways that we do that is you want to start them on the prophylactic pharmacological agents such as the anticoagulants, because you want to make sure that they won't clot and have complications. And then when they are released from the hospital, you want to make sure that they also go on an anticoagulant in order to continue monitoring to make sure they don't develop a DVT. If you assess them and you decide that they're a low risk and that they would be less than a 72-hour hold in the hospital, then you can manage them with the mechanical anticoagulation. And this, for example, is putting on compression socks or something that helps decrease stasis of venous blood flow. And now I'm going to talk about the conclusion. So with this case, we learned that it's very, very important that people with irritable bowel syndrome, specifically ulcerative colitis, have to be managed with an anticoagulant. They are 8 times more likely to have coagulation, and so controlling flare-ups properly and managing this disease is critical. So some ways that you can properly manage this is making sure you're monitoring their vital signs and their stool output. As stated earlier, this patient presented with blood in their stool for quite some time, and also managing their vital signs will allow you to know if they're having an acute flare-up. The other thing we can do is check their hemoglobin levels. If it's less than 9, then you want to start a blood transfusion because you don't want them to go to hypovolemic shock. Another thing that's very important is that you put them on an anti-inflammatory for their acute flare-ups. The other thing that we wanted to address is that you do not want to put them on NSAIDs because there's an increased risk of bleeding with NSAIDs, so this would be contraindicated in most patients on an anticoagulant. And the whole conclusion of this is that patients are very high risk for developing DVTs and clots, so that you need to make sure that you start them on the anticoagulants when they're hospitalized in order to make sure that they're properly managed for their disease process. Thank you for your time, and we look forward to seeing you in the conference. Thank you. Bye.